एंड करना हो तो कैसे करना है? ठीक है. Good morning all. So let's just revise what we had learned about primary vasculitis, major types. So primary or idiopathic vasculitis are a rare group of, you can say, autoimmune disorders, and as we had discussed and emphasized in the last lecture, that probably clinically speaking, vasculopathy and thrombotic disorders of arteries are probably the more important causes. So clinically, vasculopathy like atherosclerosis and thrombotic disorders, because of acquired and inherited coagulophilias or coagulopathies, are probably more common than primary vasculitis. But primary vasculitis are important to be recognized early because their management depends on the immunosuppression and immunomodulation. Very timely intervention is needed because many of these disorders may be life-threatening. Okay, so it's important to recognize primary vasculitic disorders, even though they are very rare. It's important to recognize their disease pattern. Okay, so we had discussed about the various types of vasculitis, how depending on the size of vessel, there are different types of vasculitis. You have to only recognize that this distribution of vessel involvement is only indicative, because many patients with medium vessel vasculitis may have small vessel may have some features of medium vessel vasculitis, some patients with giant cell arteritis may have medium vessel involvement in the form of temporal arteritis, for example. Okay, so there is no watershed. It's an indicative classification of vasculitis for a clinical approach. Okay, and the second thing we had discussed in the last lecture was that we are nearly done away with the eponymous terms. So Wagner's, Church-Strauss are out because of their questionable Nazi background of the persons against whose name these disorders were named earlier. But we still have Japanese names, like we still have Takayasu and Kawasaki. Okay, so there is a trend, or the consensus now is to move away from eponymous name and names like from Wagner to GPA, and from Church-Strauss to EGPA. Okay, so in the last lecture we had just will bring you to a table in which we had discussed the various clinical presentation of each type of arthritis, and then okay, so as is understood, the large vessel usually implies the aorta and its branches, and the classical diseases in which vasculitis in which they are involved are giant cell arteritis, which presents in the above 60 years. Its classical association with polymyalgia rheumatica, and the clinically patient may have high risk to develop permanent vision loss, which is what the emphasis was about. Okay, and on contrast, Takayasu arteritis is the arteries of the young individuals, and it usually is more common in the South Asian subcontinent, and it can present as a secondary hypertension, pulseless, means upper limbs may be pulseless, there may be unequal pulses, and some patient may present with renovascular hypertension in the young. Okay, so we also had discussed that probably if you go back, that gold bed kidney model was the earlier model which demonstrated that any obstruction of the renal arteries will manifest as renovascular hypertension. Okay, so that you will be wise to revise it in your physiology notes. Okay, so large vessel can present because of involvement of the, for example, because of the brachiocephalic or external iliac involvement, it can cause limb claudication. Limb claudication is the you can say ischemia of the musculoskeletal component of the limbs because of the restriction of blood supply, which is outpaced by the demand because of the exertion. There can be asymmetric blood pressures, there can be absent pulses, bruit can be palpable or heard, and thrill can be palpable and bruit can be heard. There can be aortic dilation, and last there can be renovascular hypertension. Medium vessel, we have discussed two types of medial vessel vasculitis. One is PAN, second is Kawasaki. Polyarteritis nodosa usually involves above 50 to 60 years, more common in males. It can present with it can present as fever of known origin or PU, what you will learn, and usually it spares the small vessels. So glomerulonephritis and pulmonary capillaritis is not a feature of PAN, which is always also one of the questions asked in MCQs. Okay, so microscopic cholangitis can involve the small vessels like pulmonary capillaries and renal capillaries in the form of glomerulonephritis, but PAN does not involve those small vessels. Okay, so earlier it was the microscopic PAN was one of the terminology used, but it is no longer used. So PAN is a different entity and microscopic cholangitis is a different entity. So PAN can involve bronchial arteries, but involvement of pulmonary capillaries and presentation with pulmonary hemorrhages is extremely rare, or it's not there in polyarteritis nodosa. Okay. The another type of medium vessel vasculitis is Kawasaki, but we have not dealt it in detail. I will prefer that you might be taught that in your pediatric classes. Okay. So in polyarteritis nodosa, the presentation can involve the medium vessels. So it can present as dermatological manifestation like subcutaneous nodules, non-healing ulcers, livedo reticularis. Okay, so it can also present with distal gangrenes. When it involves the nerves, it can also present as mononeuritis multiplex. So we had also discussed in the last lecture that mononeuritis multiplex is the vasculitic involvement of the nerves. Okay, so it is different from the more common distal symmetric polyneuropathy, which is Lang dependent, while mononeuritis multiplex is a non-Lang dependent, you can say random involvement of any nerve can be there in this disease. So mononeuritis multiplex is a classical presentation with polyarteritis nodosa. Okay, so and because of the involvement of the renal arteries, it can also present with renovascular hypertension. If we perform angiography in this group of patients, sometimes we can also find mesenteric artery aneurysm, or these small artery aneurysms can sometimes be found on angiography. Okay, but more or less the criteria for diagnosing polyarteritis nodosa Kawasaki are clinical plus radiological, like that. Okay, there is no specific criteria. Even for large vessel vasculitis, there is no such marker, autoimmune marker, which can help us to diagnose. Okay, so most of this large and medium vessel vasculitis are based on a collection of clinical and radiological patterns. Okay, and many of them have to be diagnosed after ruling out vasculopathy and thrombotic disorders. Okay, so that has to be kept in mind. But this is not in case of small vessel vasculitis. for small vessel vasculitis, we do have some autoimmune markers, so we'll come to that. So the presentation of small vessel vasculitis can they can present as palpable purpura. Okay, so purpura, we can say that is a hemorrhage in the skin. So usually it can be a part of any platelet disorder, scurvy, etc. can present with purpura. Okay, thrombocytopenia. But when it is palpable purpura, usually we mean to imply a vasculitic cause. So small vessel vasculitis is one of the causes of palpable purpura. It can also present in vesiculobullous lesions. Patient can have urticaria. Okay, so not all urticaria have this small vessel vasculitis. A small proportion of urticaria may be due to urticarial vasculitis. Most important presentation is glomerulonephritis and alveolar hemorrhage. Okay, so in addition, there can be granulomas in other organs. For example, in GPA, we can have involvement of the upper airway granulomas. Sometimes there can be ophthalmic involvement. Okay, so patient can have uveitis, scleritis, episcleritis. Okay, so in addition to this renal and pulmonary vessel involvement, patient can also have involvement of the eye in the form of uveitis, episcleritis and scleritis. So it has a widespread involvement and we have to have a high index of suspicion. So as discussed, Wagner is this group of disorders in which are characterized by presence of autoantibodies known as anti-neutrophil cytoplasmic antibodies are now clubbed under the term ANCA-associated vasculitis. Okay, so they primarily affect the small and medium-sized arteries, and they have three disorders included in them. So one is the granulomatosis with polyangiitis, which was formerly known as Wagner's, microscopic polyangiitis or MPA, and eosinophilic granulomatosis with polyangiitis or EGPA, which was formerly known as Churg-Strauss. A small proportion of patients can only have renal limited necrotizing vasculitis. Usually it is histopathologically it comes under the group of pauciimmune necrotizing or presenting glomerulonephritis. Okay, so ANCA-associated vasculitis, you can consider that they fall under the this umbrella term of ANCA-associated vasculitis. So anti-neutrophil cytoplasmic antibodies are against some cytoplasmic antigens, for example, against proteinase 3, myeloperoxidase and lysosome-associated membrane protein 2. Okay, so those are the target antigens, and the CNK, PNK are this pattern which is seen on immunofluorescence when the antibodies from the serum in the patient bind to this neutrophil substrate placed on a slide. The pattern of this binding is what we see as a cytoplasmic pattern or as a perinuclear pattern. Okay. Sometimes what happens that because this P and K is perinuclear, means there is a perinuclear affinity or perinuclear presentation of immunofluorescence, so sometimes it can be confused with ANA. Okay, so if ANA is also positive and P and K is also positive, so sometimes we have to rule out false positive pattern because of the ANA positivity, because both of them, both ANA as well as P and K, can be confused because of the involvement of the perinuclear pattern of immunofluorescence. Okay, so GPA should be suspected when patient has both upper respiratory, lower respiratory and renal involvement in the presence of obviously characteristic ANCA antibodies. So, upper airway involvement can be in the form of any sort of, means patient can have chronic sinusitis, patient can have nasal crusting, nasal bleeding, nasal discharge, patient can have non-healing, or patient can have oral ulcers, patient can present with serious otitis media, and there can be involvement of the laryngeal apparatus, there can be hoarseness, there can be subglottic stenosis. You might have seen pictures in your books about the destruction of the nasal cartilage leading to depression of the nose. So, apart from leprosy, probably Wagner is the only disorder commonly which I know that it can cause a destruction of the nasal cartilage and can cause depression, apart from other traumatic and other causes. So, so it can cause involvement of the nasal cartilage, resection of the nasal cartilage, and there can be depression of the nasal septum. So, if patient has a recurrent symptoms of upper respiratory involvement, upper airway involvement, and patient also has lung involvement. The lung involvement can in the form of nodules, cavities, infiltrates. Okay, some patient can also present with alveolar hemorrhage syndrome. So patient can also have soft fluffy shadows, and patient can have acute onset respiratory failure. So if presence of both upper respiratory and lower respiratory involvement can be one of the features of small vessel vasculitis like Wagner's. So, in addition, the characteristic involvement is that of the glomerulonephritis, that is pauciimmune, focal and segmental, necrotizing and often crescentic. Okay, so clinical correlation is that patient presents with acute renal failure or rapidly progressive renal failure. Okay, and patient may have other features of acute glomerulonephritis, like patient may have some patient may have gross hematuria, patient may have hypertension, patient may have volume overload, and okay, so some patients are very sick because there is a rapidly progressive renal failure, and we should have a high suspect of high degree of suspicion to consider this group of disorders, because timely intervention is very important to prevent any damage. So we have lost patients despite early aggressive management, and the patient have presented with acute progressive renal failure, and despite intervention many of these patients succumb to their illness. So but still it should have a high degree of suspicion to consider this group of diseases. So GPA can be strongly associated with both C-ANCA as well as C-ANCA and anti-proteinase 3 antibodies, but other antibodies can also be associated, like P-ANCA can also be occasionally associated with GPO, but the strongest association is that with C-ANCA pattern and anti-proteinase 3 antibodies. So as we can see in this X-ray, there are some nodules, there are some cavitations, some nodules with cavitations. So this is one of the characteristic presentation of pulmonary involvement in GPA, but there are important differentials to rule out. Okay, so for example, in Indian subcontinent, for example, tuberculosis is much more common than GPA. So always we have to rule out other causes of this lung nodules like tuberculosis first before labeling the patient as ANCA-associated vasculitis, because by prevalence wise tuberculosis is many times more common than Wagner's. So in this table it just mentions the prevalence of various types of ANCA antibodies in this ANCA-associated vasculitis group of disorders. So as you can see, the characteristic antibody is anti-PR3 or C-ANCA, but Anti-MPO can also be seen in about 1/4 of the cases, and some of the cases can be, a minority can be negative also. Okay, so for microscopic PAN and renal limited vasculitis and eosinophilic granulomatous with polyangiitis, anti-MPO is the more commoner association. Anti-MPO or PNK is the more characteristic associated antibody, though in the majority of them they also can be associated with CNK. So mainly we have this antibodies are very specific for those ANCA-associated vasculitis, but the overall patient should be diagnosed based on the entire spectrum of clinical involvement. Okay, so and we can see that many of them can also be CNK means ANCA negative. Okay, so either of them can be seen in all these group of disorders. Both CNK and PNK can be seen in all of this group of disorders, but as a rule of thumb, if you want to remember, that CNK is more characteristic of GPA and rest all are associated with PNK. That's all you need to remember. Okay, so how to treat? The first issue in the part of treatment is actually the recognizing the clinical syndrome. If patient has both upper respiratory or lower respiratory involvement along with renal failure, then, and especially with glomerulonephritis like presentation, you should have a high threshold to low threshold to diagnose this group of diseases, and if you perform ANCA, many of them will turn out to be positive, and we have to treat aggressively with high dose steroids. If patient has a very severe organ threatening illness, the first line management is basically the high dose steroid with cyclophosphamide. Okay, many of these patients can also be given other immunomodulators, like for example many patients may benefit with, for example, those who have renal failure. If you want to remove the antibodies, we can also perform plasma exchange. Many patients we can also give rituximab. Okay, for maintenance now, for at least serious organ involvement, we always prefer rituximab can be preferred as a maintenance in current regimens, especially for relapsing disease. If patient has a relapse, then we can prefer rituximab over cyclophosphamide. This is the widening horizon of the immunomodulator therapy. That's all you need to understand, that immunomodulation, and patient may need to be given immunosuppression for a long period, for 2 to 4 years. So this is a comparison of the 3 types of ANCA-associated, this two ANCA-associated and one with the PAN. Renal vessel vasculitis with infarct and microaneurysm is a feature of polyarteritis nodosa because it is a medium vessel artery involvement is there, while it is not a feature of MPA and GPA. Similarly, rapidly progressive glomerulonephritis is not a feature of polyarteritis nodosa, while it is a feature of small vessel vasculitis like MPA and GPA. Similarly, as we had discussed, PAN does not involve small pulmonary capillaries, so pulmonary hemorrhage or alveolar hemorrhage is not a feature of PAN, while it can be seen in MPA and it can be occasionally seen with GPA also. Okay, so we had discussed Hep B involvement or chronic hepatitis B infection can be a feature of polyarteritis nodosa, while it is not an association seen with MPA or GPA. So very occasionally we can have PNK antibodies in PAN, but they are characteristically associated with microscopic polyangiitis. Okay, so PNK or anti-MPO antibodies can be a feature of MPA and can be seen in small minority of Wagner or GPA also, but it is very uncommonly seen in PAN. So if we perform the angiography in this group of patients, in PAN we can have we can see that they have some microaneurysm formation, but because MP and GPA are mainly capillaritis and small vessel involvement, we usually don't find any changes like aneurysm, microaneurysm. So on histology, there can be necrotizing vasculitis in polyarteritis nodosa. In MPA, there can be necrotizing vasculitis, but granulomas are not seen. And as in the name, it suggests that there is granulomatous vasculitis, which is characteristic of Wegener's. Okay, so relapses are rare in PAN, while they are common in both MP and GPA. So this is the some basic clinical spectrum of this group of disorders you should be able to recall. Okay, so coming to eosinophilic granulomatous with polyangiitis. So the characteristic feature of this group of disorders is the eosinophilic infiltration of the tissues. So the name itself suggests the term eosinophilic granulomatous with polyangiitis. So it can also present with characteristic upper airway involvement with rhinitis, polyposis, sinusitis, and some patients have adult onset asthma. This patient can also have mononeuritis multiplex. Patient can have subcutaneous nodules, purpura, petechial rashes, and there is peripheral eosinophilia. Okay, so this group of disorders, you can say, is a small minority of patients who present with asthma and eosinophilia. Okay, because the more common presentation is that of atopic disorders or patients who have asthma and eosinophilia. Okay, only minority of the patients will have EGPA. Okay, so by and large, most patients which we will encounter with asthma and patient have upper respiratory symptoms are basically atopic or allergic in nature, while a very small minority of them might be having EGPA. Especially if they have other involvement, for example, if they have neuropathy, if they have subcutaneous nodule, okay, and so in this small group of disorders we can suspect EGPA, but it is very, very rare compared to the more common garden variety asthma. This vasculitic form of asthma is very, very rare. Okay. So if we compare the similar looking terms like eosinophilic GPA with GPA, the ENT in ENT involvement, there in EGPA there can be rhinitis and polyposis, while in GPA there can be necrotizing granulomas. Allergic manifestation, bronchial asthma are frequent in EGPA, while they are more frequent than in the general population. Renal involvement is not common in Churg-Strauss, or which is now relabeled as EGPA, while it is one of the most characteristic and common manifestation of Wegener's. So eosinophilia can be seen, and while it is uncommon in or minimally elevated in GPA. Histology may reveal that the necrotizing granulomas have eosinophils, while they have GPA, they have necrotizing epithelioid granulomas. So the major cause of death in EGPA is basically because of the cardiac involvement, while it is pulmonary and renal in GPA. While PNK or anti-MPO are characteristic autoantibodies present in EGPA, CNK is the predominant antibody which is seen in Wegener's. Okay, so or GPA, what we'll now call it. So this is the spectrum of involvement. So if you just recognize the difference, you probably will recall all the clinical features. So as for Wegener's, the major treatment protocol for EGPA also involve high dose steroid with or without cyclophosphamide, depending on the degree of organ involvement. We can also use anti-CD20 monoclonal antibody, which is known as rituximab in the management of this group of patients. Okay, so I think we can conclude our vascularitis lecture today. So I think it will be pertinent if you just go and revise certain terms, because we have discussed them many times in these talks. So it will be good if you can just go and look at the classification, histopathology classification of glomerulonephritis, in which one group goes to autoimmune glomerulonephritis. Okay, so just go through the table of autoimmune or approach to glomerulonephritis, then it will give a wider perspective to you. Second thing is, if you could go back and just look at the various presentation of neuropathies. So just to have a wider perspective that what we are actually dealing with. Okay, so and the third important part is if you have yet not revised, so because it's an important part of pathophysiology of renovascular hypertension, it will be pertinent if you will go back to your physiology books and look at the Gallbladder cleaning model, how the renovascular hypertension happens, why does it happen, and what can be the modalities to manage. Okay, it is a very important chapter if you want to consider for your exam point of view.